context of that was really just to highlight parts of the conversation that I'd already been having with the local politicians in relation to developing their understanding of the state of play in the health service at this point in time. And I know what had been exercising them all greatly had been these huge waiting times in the emergency department. And certainly from the evidence that we have and that's available in all the trusts across Northern Ireland, we know that there aren't any more people attending emergency departments than there were 3 years ago. But what we do know is that their length of time waiting there is much longer. And that's directly related to our difficulties in being able to get people home once they've finished their episode of medical care in a timely fashion. So one of the things that we know is that pre-pandemic, we would have had in and around 20 people who were delayed in hospital waiting for care packages. At any given point in time across Northern Ireland, now we have 500 people a day who are waiting on care packages or are delayed in hospital because of absence of other things. And in the Southern Trust, that's a particular challenge for us because we could have in and around 70 to 80 people a day who end up being delayed. The difficulty with that is if you think about an average length of stay for any patient should be in and around anything from about 3 to 6 days. Those patients are getting delayed for weeks and months at this point in time, so that means that the use of that bed for other patients then isn't available, and that slows down then the numbers that we can manage in each of those beds. But on an individual basis, what's really important for those patients who are stuck in hospital is that we know, particularly with frail elderly patients, that they start to decondition. So our geriatric colleagues are very exercised about this and they're extremely worried about it. They feel that we have got increasing numbers of frail elderly people who get delayed in hospital, who as a result of that, because they don't move about as much as they do in hospital, because they're out of their own environment, because they're not in a place that's non-clinical, they increase the risk of muscle weakness that then in turn leads to falls, the disorientation and out of their environment for a long period of time increases their risks of being confused, losing confidence and concentration, and actually becoming increasingly depressed, right? So from an evidence-based point of view, we know that if you're delayed in hospital longer than your acute episode of care, we run the risk of actually doing you harm. So part of my message that day to Newry and Mourne Council was around the absolute necessity for us to get people home as quickly as possible so that actually we could reduce any risks to them. And for us, it's always about the balance of risk. And I think what I was trying to explain and have explained to the politicians in recent times is that, you know, there will be people who will be much better off at home, even with a smaller care package, waiting for that to be completed in the way that they need, rather than sitting for long periods of time in a hospital bed. And that was the message to the politicians. And I have to say, in the previous discussions that I'd had with all the 5 political parties, I think they were very grateful for the knowledge around that hadn't been made as explicitly clear to them before, and certainly were very supportive of what we've been trying to do in terms of working with the community, working with families, working with our patients to try and reduce the length of time that they're actually in hospital so that we can make sure that they have much better outcomes, but also that we can make sure then that it has a much lesser impact than all of those other frail elderly people who are sitting in trolleys in our emergency department, other people's emergency departments, sometimes for days at the time because we can't access a bed for them. So that's what the message was, and I think the bit that was quoted was part of a much bigger message. I appreciate that, you know, when it's read coldly like that, it looks quite blunt, but that's not the entire message. You know, the perspective comes from I think, a very clear understanding on our point just of how this whole system fits together, the absolute necessity for us to try and provide the best care that we can in a very difficult situation, but an understanding that hospital, once the acute episode of care is over, is often not the best place for any of us, and that we do need to try and get home as quickly as possible and have people looked after at home. The other thing just to say is that from our own experience, we have a significant proportion of people that when they get home, they actually need less input from the care system than we have anticipated that they might, okay? Because very often our assessments are done in hospital where people are not, functioning at their everyday level. And very often what we find is when we get the person discharged home, actually, they don't need as much input as we thought that they did. And again, that's really important, because one of the things that we know particularly impacts on a frail elderly person is the loss of confidence. And it's really important. I know one of the things that a lot of our patients find very difficult is the dependency on us, the loss of their independence and their privacy and all of that. So it's really important from our point of view to try and get them home, to re-establish that level of confidence and independence, and also to improve their health outcomes in terms of their mobility, the risk of infection control, the risk of confusion, the risk of deteriorating mental health. So that was the rationale behind some of the discussion that was held that evening, rather than it purely being about just asking people to go home.
And I suppose, what would you say to people who sort of have concerns that they might have relatives being sent home without the full care packages? Because I suppose in the wording of the article, people might think people are just being sent out.
We risk assess that for every individual who's there, right? And there will be times that families will say to us that they want to take somebody out, and we'll be advising them not to, right? Because we actually don't feel it's safe enough for them to do that, right? So, our advice is always based on our best evidence, right? And also with the patient, in the centre of our minds whenever we're making those decisions or giving those opinions, right? We also know that, just because we discharge a patient from hospital doesn't mean that we lose interest in them, and that, what we're saying to people is we may not be able to get to the full package of care this week, but over the next couple of weeks we will be. But if you can manage to take the person home, if you can make other arrangements around them for short periods of time to allow us to get that in place, that's still the better option. And we're appealing to people to work with us to do that, and the vast majority of people do, to work with us basically to try and get our older, frailer people in particular home, to try and improve their health outcomes and keep them safe.
So I suppose really the circumstances in the health system at the moment you're saying they don't allow for a full package of care for every patient going out necessarily? Not every patient. Now we do have, every day in the Southern Trust we provide 5,000 care packages. So it's not that we don't do this on a daily basis, right? But what we know in recent times is because of the challenges with food and fuel poverty, that the domiciliary care provider system in particular and some of the care home sector are struggling to recruit staff, right? Now, to offset that, we have taken back some of their packages, and we've been trying to provide that in-house with some of our own staff. We're all faced with staffing challenges across the NHS in Northern Ireland. But with all of that, we have been trying our best to share the allocation that we actually have. We are commissioned by the SPPG in the department to provide certain levels of care packages, and we have been over-providing in relation to that, to try and get as many people home as we possibly can, and to provide as much independence for them in their homes as we can. But there will always be, at this point in time, because of the shortages of staff in the care sector, there will always be a percentage of those people that we're providing for who will not automatically get access to the full care package immediately, and it will take us time to build that up. It's a very dynamic and fluid system. So what we will find is that very often, within the first few weeks of people going home on full care packages, that maybe by week 2, 3, 4, they might need lesser. So they might start with 4 visits a day, and by the end of that they might only need two visits a day. And if that's the case, then we can move those 2 visits a day to try and support somebody else. But we discharge significant numbers of patients across the whole of Northern Ireland on a daily basis to different areas in Northern Ireland. It's fluid, and if we can free up capacity anywhere to try and support people, we will definitely do that.
I'm just sort of drawing back from that meeting in Newry, Mourne, and a councillor, Hugh Gallagher from the SLP, said that sending people home from hospital wards with incomplete home packages can just end up in patients returning back to hospitals in a matter of weeks, and we're back to square one. Do you think that isn't really taking in the full picture of the situation?
I know that that's an anxiety, right? That certainly hasn't been our experience, okay? So there will always be situations where home circumstances break down, and very often we have patients admitted to hospital because of that, right? That, in our experience, is rarely purely about a care package. It's often about a much wider problem, right? And certainly that wouldn't be a huge source of concern for us in terms of people returning to hospital. What we do know is that if we get people out at the earliest possible stage into their own homes, their chances of remaining in hospital independently for much longer in their own homes is much greater. So the sooner we can get people out, the longer we will be able to maintain them successfully at home, because we run the risk that if we send people home after significant delays, that actually, because of the loss of confidence, because of the deconditioning, because of the potential risk of reinfection and everything else in hospital, that actually we send them home in a weakened state, and actually then their situations runs the potential then of deteriorating. Whereas if we can get them home much earlier in a much more clinically fit state, actually the chances of their care package, their health holding up, all of those kind of things is much stronger. So again, it's really important that we get people home as early as we can.
So you're saying that if the idea of waiting for the full package is almost counterintuitive?
Yes. Yeah, if it's possible to go home at all with some support for short periods of time to give us time to get everything sorted out, then please take that, because as you say, it is for some it's counterintuitive. We run the risk of actually not being as helpful as we possibly can to the patient by actually keeping them in hospital.
Mm-hmm. What would your appeal be to public and politicians, who have their concerns?
I think particularly with there being shortages across the NHS, I think people are always very worried that if they lose hospital, they won't get care, right? If they leave hospital, they won't get care. So I think from our point of view, it's to reassure the public that Southern Trust is a very community orientated trust. We believe that the vast majority of the care that we carry out takes place in the community, and that's where our focus is. And it's to reassure the public that once you've had your acute episode of hospital care, if you leave, with the advice of doctors, nurses and everybody else, and take up the best option for yourself at that point in time, we will continue to support you as long as you need us to. We will not abandon you because you're in the community.
How would you explain the domiciliary care package process, and how do you deem who needs what, in a sense, before it's suitable to let people out, or whether you would deem it that someone should stay? Makes sense.
So it's based on a multidisciplinary team assessment, right? So very often it will be based on the observation and opinion of the doctors, the nurses, often involving physiotherapy, speech and language therapy, occupational therapy. So it's quite a complex process, but also then in consultation with the patient and their family or their carers, okay? And being cognizant of what the home situation is like. And then often our teams will then carry out an assessment of the person while they're on the ward, right? Now, bearing in mind that we're trying to assess people in alien environments from their point of view, understandably what we tend to find is that people are a bit more cautious, they lack independence in that scenario, and we don't get a full picture of what they're actually like. So one of the things that we've been trying to drive within the Southern Trust has been Discharge to Assess, where basically we're trying to get people home and then carry out the assessments very quickly after they go home to then decide what it is they actually need, and we find that those are a lot more accurate, right? But the other thing we know is that, again, if there are delays for whatever reason in the person going home, and those assessments very often then have to be repeated because, you know, potentially if you're in a hospital bed longer than an acute medical admission requires you to be, and you're delayed for whatever reason, actually your needs change throughout all of that. So that necessitates us repeating the assessment, but very often what we find is that by the time the second assessment then is done, the person actually needs more care because there has been a deconditioning, a loss of confidence, you know, a vulnerability to other, you know, aspects of care during that period of time, and then actually their care needs increase. So again, what we find is if we can get people home in a timely fashion, actually their care needs are less, but for good reason, and that they're less deconditioned and they're more confident and independent than they were after they've had long periods of stay in hospital.
Yeah. So as you said, it's a vicious cycle if they just say.
Mm-hmm.
So that's why, you know, it's important the public know that it's they're not being thrown just.
No,
put
absolutely
out.
not. No.
It's a rigorous sort of process.
No.
You know, and it's working within the confines of the system that we have at the moment.
Yes, yeah. And I think, you know, the population of Southern Trust who've had frail elderly people in particular come through our emergency department, I mean, they have seen how difficult that is for very unwell and frail people to be on hospital trolleys, you know, throughout the night, sometimes throughout 2 nights, waiting for a bed, you know, while we try to create capacity for them to actually come onto the ward and everything else. Mm-hmm. So I think the people in Southern Trust realise how difficult this is, but I think, you know, what I'm trying to do is to reassure them that it's okay to go home once you're medically fit to go home. We will continue to provide, and actually in terms of getting the best outcome, that is the best thing to do. And it means that then the next time, you know, if there is a next time that, you know, your relative needs, you know, admission through an emergency department and needs to come through that pathway again, that actually we can get them through it much more quickly because we don't have delays in discharge. So we'll not be continuing this cycle of being delayed on hospital trolleys in an emergency department waiting for space to come up.